Hey guys, welcome back to my channel, The ENT Resident. Today we'll be talking about myringotomy and Grommet insertion procedure. We'll talk about what are the uses of this, what are the indications, the contraindications, and how do we perform this surgery, and what are the complications of this surgery. You can also now purchase my notes. I have added links in the description. Okay, let's get started. So, what is myringotomy? Myringotomy is when we are making a very small surgical incision in the tympanic membrane to evacuate the middle ear fluid. And we combine this procedure a lot of the times with Grommet insertion. What is Grommet insertion? It is a ventilation tube that we place into that incision that we have created during myringotomy to ventilate the middle ear, maintain its aeration, and allow discharge to drain out. So these two procedures, they're usually combined together in a lot of indications, which I'll talk about in a little bit. So what is the purpose of doing this surgery? So when we are doing a myringotomy and placing a ventilation tube inside, our major purpose over here is basically to bypass the dysfunctional eustachian tube. So we all know that the function of eustachian tube is to equalize the middle ear pressure. In a lot of cases, like for example in otitis media with effusion, the eustachian tube is not functioning properly. So as a result of which, it is not able to ventilate the middle ear, and also this leads to the development of this negative middle ear pressure and accumulation of fluid within the middle ear. So this surgery is done so as to bypass that function. Second, once it is ventilating the middle ear, it is relieving the middle ear of the negative pressure that is developed in these cases, and therefore preventing the fluid accumulation that happens in case of otitis media with effusion. Third, it is also draining this fluid, the drainage of effusion that is occurring inside the middle ear, and therefore restoring the hearing loss that is seen in otitis media with effusion. And as a result of otitis media with effusion, whatever symptoms we see, which can be pain, tinnitus, vertigo, which develops because of the high negative middle ear pressure, those are also alleviated by putting in the Grommet tube inside. And lastly, as a result of which, it is preventing any permanent structural damage to the ear. So these are the reasons why myringotomy and a Grommet insertion is massively going to help a case of eustachian tube dysfunction. Now, let's talk about what are the indications of this surgery. So, first of all, as I mentioned, our primary indication over here is otitis media with effusion, or OME. Can you tell me what are the other names that OME is known by? It is also known as glue ear because of the glue consistency like effusion that develops in the middle ear. Also, it is known as serous otitis media, also known as secretory otitis media, and the last name is non-suppurative otitis media. So we have a lot of synonyms for this condition. So even in otitis media with effusion, we do not do Grommet insertion in every case. There are particular indications for it. We usually try to observe the case and give medical management, but in certain scenarios, for example, first is chronic otitis media with effusion. When do we call it a chronic case? When it has been unresponsive to antibiotics and other medical management and has persisted more than 3 months when it is bilateral, or more than 6 months when it is a unilateral disease, or even earlier than this if the hearing loss is more than 25 decibel. Second indication is when we have a recurrent acute otitis media with effusion, where we see at least 4 episodes per year. And third indication is when acute otitis media with effusion has complications, for example, facial palsy, vertigo, etc. So these are the indications of putting in a Grommet in case of otitis media with effusion. But other than OME, we also have a lot of other indications where Grommet insertion can be helpful. For example, in cases of recurrent acute otitis media, when do we call it recurrent? When it is more than equal to 3 episodes in 6 months, or more than equal to 4 episodes in 12 months or 1 year. Other than this, even in cases like adhesive otitis media, where the tympanic membrane gets plastered to the promontory, to the middle ear, In that case, also this will help. Atelectasis of tympanic membrane, persistent retraction of tympanic membrane. These are all scenarios where there is negative pressure developing inside the middle ear. Even in cases of hemotympanum, which is not spontaneously resolving, those cases, doing a Grommet insertion will help resolve the situation. Other indications are patulous eustachian tube causing autophony, chronic eustachian tube dysfunction, otitic Barrett trauma, which is unresponsive to medical management. And last, a very important MCQ question over here is in intractable cases of Meniere's disease who is having severe attacks of vertigo. In all of these cases, doing a myringotomy and a Grommet insertion is going to help the situation. Next, let's talk about what are the contraindications. When will we not do this surgery? So, our first contraindication here is when it is an only hearing ear. It is important to remember why, because in an only hearing ear, there is a risk of postoperative complications happening in as a result of this surgery. So, if that happens in an only hearing ear, you actually risk total deafness to the patient. So, unless it is absolutely necessary to perform the surgery in these cases, you should not perform them. And if we do perform, we should inform the patient of the possible complication of deafness over here. Second contraindication is when you have an intratympanic glomus tumor. Now, we know that glomus tumor is a very highly vascular tumor, and we know that it's located in the just behind the tympanic membrane. So, when you're performing myringotomy and you're trying to insert the Grommet tube, you risk coming in contact with a glomus tumor, and which can lead to risk of very profuse bleeding, which can be very difficult to control. Third contraindication is having a dehiscent jugular bulb. So, if a jugular bulb which lies in the floor of the floor of the middle ear, if the jugular bulb is dehiscent, in that case, again, you risk an injury because we usually give a incision of myringotomy in these cases in the antero-inferior quadrant. So, it is very close to the floor of the middle ear cavity. So, if there is a dehiscent jugular bulb, you risk having catastrophic hemorrhage in case it is injured. Next is middle ear neoplasm. We should, if there is any suspicion of middle ear neoplasm, we should be very careful about doing this procedure. Some relative contraindication would be acute otitis externa when there is infection of the skin lining the external auditory canal. This is a relative contraindication. Usually, we'll not be doing the surgery in this case. We'll try to treat the situation and then do the surgery because there is an increased risk of postoperative infection. However, if it is absolutely required to do and you cannot wait for the surgery to be done, in that case, we can perform the surgery even with acute otitis externa after starting the patient on antibiotics. Next contraindication is having an atrophic tympanic membrane. Now, if the tympanic membrane is atrophic, it may not be able to resist pressure. It does not have enough strength. So, when you try to give an incision and try to put the tube in, first of all, is it may not be able to retain the tube in position for long. So, the tube may get dislodged into the middle ear, or you can also end up risking permanent perforation of the tympanic membrane. So, these cases are not ideal cases for doing Grommet insertion. Next is if there is an external auditory canal stenosis. So, if the external auditory canal is very narrow, you will not be able to access the tympanic membrane. So, then obviously it ends up becoming a contraindication because you cannot access the tympanic membrane to put in the Grommet. Last of all, any uncontrolled systemic disease like hypertension, diabetes mellitus, etc. In these cases, you also pose an increased anesthetic risk and even an increased operative risk. So, these are all our contraindications which we should keep in mind when we are planning for a case of myringotomy with Grommet insertion. Now, let's assume that we have a patient that we want to operate on. How are we going to approach this case? First of all, we have to do pre-operative evaluation. So, after you have taken the history and come to a diagnosis, certain things that you need to do is, first of all, you should perform a pneumatic otoscopy. This will help in confirming a diagnosis of otitis media with effusion or retracted tympanic membrane or whatever other scenario that you are doing the surgery for. Second is we need to do a pure tone audiometry preceding 3 months, or if not pure tone audiometry, we should do an age appropriate hearing test to document the hearing loss that the patient has. Third is we should do a tympanometry. Can you tell me in tympanometry, in cases of otitis media with effusion, what kind of curve will you be seeing? This is a very important question. The curve that we will see is a flat B curve. And lastly, in these cases, we should also examine the nasopharynx as well as the neck. If needed, we perform a diagnostic nasal endoscopy, a nasopharyngoscopy, so as to rule out any pathology that may block the eustachian tube. A very good example of this would be nasopharyngeal carcinoma. Now, can you tell me what is the most common presentation of nasopharyngeal carcinoma? That is cervical lymphadenopathy. Now, in certain scenarios, you may not find a primary in the nasopharynx, but the one of the presentation could be metastatic cervical lymph nodes with an unknown primary. And later, once you perform some blind biopsy from the nasopharynx region, you may end up diagnosing it as nasopharyngeal carcinoma. Nasopharyngeal carcinoma can also cause eustachian tube block because the most common site of development of nasopharyngeal carcinoma is fossa of Rosen-Miller. Now, fossa of Rosen-Miller is located just posterior and superior to the opening of the eustachian tube, which lies in the lateral wall of the nasopharynx. So, therefore, a mass in that region can end up blocking the eustachian tube, leading to eustachian tube dysfunction, and as a result of which, you can end up developing serous otitis media in these cases. So, if any case where a unilateral serous otitis media case in an adult has come to you, you should suspect nasopharynx, some tumor involving the nasopharynx, and perform a nasopharyngoscopy to rule out any mass over there. So, that is for our preoperative evaluation. Now, coming to anesthesia, usually these can be performed under local anesthesia for adults, where we give a 4-quadrant injection to the external canal wall till the bony cartilaginous junction with 1% lignocaine with 1 in 1 lakh adrenaline. But in cases of children or infants who are not going to cooperate as much, it is preferable to do the surgery under general anesthesia. Next, how will we position the patient? So we'll have the patient in supine position with the head resting on a ring and turned to the opposite side. So the ear to be operated is turned towards the surgeon. Now let's discuss how are we going to perform the surgery. What are the steps of the surgery? So we'll usually do it under an operating microscope, and the magnification used is 6 times. And we'll use a suitable sized oral speculum for the ear. And first, our first job is to visualize the external auditory canal and the tympanic membrane. Once you have visualized the external auditory canal, we'll clean the external auditory canal of any wax or debris that might be present over there. Now we have to be careful so as to not to traumatize the external auditory canal skin, because at any point right now, if you end up causing trauma to the skin over here and it leads to bleeding, that will impede your further steps of the surgery. You need a clear surgical field to perform the surgery. So once the ESC has been cleared off, our next step is to perform a myringotomy. What does myringotomy mean? Otomy mean making an opening, and myring means the tympanic membrane. So you are basically making an opening in the tympanic membrane. So we'll take a sharp myringotomy knife. The incision that we give over here is a 2 to 3 millimeter long radial incision, and the site of the incision over here is the antero-inferior quadrant of the tympanic membrane. Now, certain questions over here that we need to understand is, first of all, if you have studied acute otitis media, which I have a video for, you can see over there that in acute otitis media, the incision that is given is a circumferential incision. Whereas in case of otitis media with effusion, we give a radial incision. Now, what is the reason for that? So there are multiple reasons over here. So if you remember the anatomy of the tympanic membrane, you can check out my video for more details. The middle layer of the tympanic membrane is the fibrous layer. Now the fibrous layer is arranged in such so that if you give a radial incision, you end up actually separating the fibers rather than cutting them. So, as a result of which, once the grommet comes out, the healing of the tympanic membrane is way better and faster. So, that is one reason. Second is, if you do give in circumferential incision like this, in that case, what happens is the edges over here they end up getting everted. And second problem with this incision is giving an incision like this cuts off the blood supply from the annulus. So these are the reasons why we'll prefer to give a radial incision in case of myringotomy in otitis media with effusion. And the incision should not be more than 2 to 3 millimeter long. You do not need more than that because that can end up in leaving behind a perforation, permanent perforation in the tympanic membrane. So that's about why we are giving a radial incision. Second is about the site. So we have four quadrants. If you remember, we have four quadrants in the tympanic membrane. This is anterosuperior, this is anteroinferior, posterior inferior, and posterior superior. We choose to give an incision in the anteroinferior quadrant. Can you tell me why? First reason is if you remember the anatomy of the middle ear, you'll remember that the eustachian tube opens into the anterior wall of the middle ear cavity. So, anterior-inferior quadrant is in actually close proximity to the eustachian tube. And second reason is anterior-inferior quadrant has lesser structures around. So, you actually this includes a lesser chance of injuring any other structure over here. So, is anterior-inferior quadrant the only quadrant that you can give an incision in? No. Sometimes you may need to give an incision in the anterior-superior quadrant also. Now, if you do end up giving in the anterior superior quadrant, can you tell me why is anterior superior quadrant chosen and not the posterior quadrants? That's because anterior superior quadrant has cells which have a very low turnover rate. That means in long term cases where you have to put Grommet for a very long period of time, we'll prefer this quadrant because the cell turnover being lower here, the ventilation tube will stay in place for longer here. It will not get naturally extruded out fast. So, in cases where we need it for long term, anterior superior quadrant is also an option over here. Next is why do we not give any incision in the posterior superior quadrants? So, posterior superior quadrant is a clear no for a myringotomy incision for Grommet insertion. That's because if you remember the anatomy of the tympanic membrane, all the ossicle structures lie in the posterior superior quadrants. So, you end up risking injury to the ossicles over here and even to the chorda tympani nerve. That is why we will not give an incision in the posterior superior quadrant. So, we have discussed about the type of incision that we are giving and the site of incision. Now, once you've given the incision, our next step would be to suction clearance. So, all the middle ear fluid or the glue that is seen is aspirated with the help of Zollner's microsuction cannula. But it is important to remember we should not do continuous and aggressive suctioning because that can end up in bleeding and noise induced hearing loss. Also, it is important to know that you do not have to aspirate all the middle ear fluid all the time. Sometimes you can just, if it is difficult to get it out, you can let it be. It will come out via the grommet. After clearing out the middle ear, we'll inspect the ossicles and the middle ear mucosa and look for any other pathology over there like granulation polyp or cholesteatoma. And then we will insert the grommet. Now, how do we do that? The grommet is grasped with a crocodile forceps. You'll see that crocodile forceps has serrated edges. Now, we grasp it in such a way so that the grommet is angled with its leading edge pointing forwards. And then we slowly slip it through the incision that we have made in the tympanic membrane. Now, as you've put in the inner flange inside, you slowly take a straight pick and you try to correctly position in the grommet so that it can lie in like this. So this is you see the outer flange and the inner flange lies in the middle ear through the tympanic membrane. After the Grommet has been adequately placed, you make sure that there is hemostasis. If there is any minimal bleeding, you control it, and usually no packing is required over here. So that's about the steps of myringotomy with Grommet insertion. I hope you have understood the steps over here and how we are doing it and where we are doing it and why. Next, let's talk about removal of the grommet that you have placed. Now, usually in most cases, we do not need to remove the ventilation tube separately. Usually, they extrude out spontaneously as the tympanic membrane heals and it pushes them out naturally. But in certain cases, you may need to remove it manually. These are usually cases where the tube overstays its purpose or causes some kind of complication. For example, if the tube has been persistent inside for more than 18 to 24 months. Second is if there is recurrent otorrhea which is not responding to medical therapy. Third is if you see any granulation tissue formation around the Grommet tube. And fourth is if the tube has migrated into the middle ear. In all of these cases, we have to plan a Grommet removal. Usually, these are done as an outpatient procedure under microscope. Usually, local anesthesia is enough. But if it's a children, a short general anesthesia is given, and we remove the tube using microsuction and alligator forceps. And we make sure to freshen up the edges in case the tympanic membrane is not healing. So that's how we remove the Grommet if it is required. So after we have done our myringotomy and Grommet insertion, how would we do post-operative care of the patient? What would be explained to them? So first of all is they should not take anything by mouth till they have fully recovered from anesthesia. Usually these are daycare procedures and same day discharge is given usually. Antibiotics are usually not required, but in certain cases, some surgeons do prescribe antibiotics. Nasal decongestants are given for 5 days. Next is if there is any ear discharge, it is cleaned by daily microsuctioning and mopping. And certain things that you have to explain to the patient is how to take care of the ear. Number one is you have to avoid entry of water in the ear, especially while the patient is bathing or swimming. Usually, swimming is not allowed, but if they want to go for swimming, in that case, they should use ear plugs while swimming and also to avoid any forceful nose blowing and sneezing because that will cause extrusion of the tube out because of the pressure buildup. So these are certain things that you have to explain to the patient as a post-operative care. Usually analgesia is not required, but if it is required, you can give a few days of analgesics. And coming to follow up, we should check the tube position at 1 to 4 weeks of the surgery and then every 3 months till the time of extrusion. Next, to check for hearing loss, we should repair the audiometry as well as the tympanometry to document the improvement in our case. Hearing improvement in audiometry is typically very rapid once the tube is patent, and even the tympanometry normalizes. So that's about a post-operative care in a case of myringotomy and Grommet insertion. Last part of our discussion today is what are the complications of putting in this Grommet inside the middle ear, inside the tympanic membrane. So we can classify our complications into intraoperative and postoperative. And postoperative can further be divided into early and late postoperative complications. So first, let's look at intraoperative complications. As we know, the most common complication of all surgery is bleeding. This can happen if there is any injury to the vessels in the tympanic membrane. Usually, it is very self-limiting and can be easily controlled. Second is if the tube gets displaced into the middle ear. Now, if this displacement has happened into the middle ear intraoperatively, this can even happen postoperatively. In that case, the management would be different. So, if it happens intraoperatively, what you should do is you should instill some saline inside the middle ear through the myringotomy incision. That will result in floating the tube up, and now you can suction that tube and take it out easily. Third is if you can cause injury to the ossicles and incudostapital joint. This is precisely the reason why we just discussed that you should not do a myringotomy in the posterior superior quadrant. You should be very careful in that area. Next complication would be an injury to the facial nerve. This is very, very rare, but if it does happen, usually the tympanic segment of facial nerve is at risk over here because it lies in proximity of the posterior quadrants. And even patients who have dehiscent facial canal are at increased risk of injury. Next is injury to high riding jugular bulb. Now, if the jugular bulb lies higher than normal in the floor of the middle ear, then the risk of injuring the jugular bulb is high over here. And if it does get injured, it can lead to catastrophic bleeding and hemorrhage. So, we should be very careful about the jugular bulb, especially if we are trying to place a myringotomy incision very inferiorly. Next complication is a injury to the oval and round window. This can happen if you do instrumentation very deeply or suction more near the promontory. This can end up in causing sensory neural hearing loss or vertigo. So these are our intraoperative complications. Next, looking at early postoperative complications, the most common of this is otorrhea or ear discharge. This can happen because of middle ear infection, even contamination during the time of surgery if you do not maintain asepsis during surgery, or if there has been a pre existing infection. Treatment is usually to involve topical antibiotic drops. Next is the tube. The ventilation tube may get blocked. This can happen because of blood clot or a mucus plug or some debris blocking the ventilation tube. This will lead to failure of ventilation, so it will not do the job that it's supposed to do. In that case, our treatment will involve microsuction or using hydrogen peroxide drops. Or if it is permanently or persistently blocked, we should remove it and replace it with a different tube. Some other common complication could be pain and irritation, but these are usually mild and self-limiting. It can happen because of inflammation occurring around the incision. In severe cases, you may use analgesics. Fourth complication is an infection of the external auditory canal, that is otitis externa. We'll treat it by doing oral toileting and topical antibiotic steroid drops. Next complication is a premature extrusion of the tube. So, if the tube has come out through into the external auditory canal even before it has served its purpose, this can happen within a few weeks either because of infection or because of placement of an incorrect size of the tube. In these cases, if the symptoms have recurred right after the extrusion of the tube, we will reinsert the tube back. Another complication is granulation tissue formation around the tube. This can happen because of chronic irritation. Usually, we'll treat these cases by cauterization and or removal the tube if it is recurrent. And last early postoperative complication is a displacement of the tube into the middle ear. I told you that this can happen even intraoperatively. When it happens intraoperatively, we usually instill saline into the middle ear and take the tube out. But if in this post-operative times, if we see that the perforation has actually healed, in that case, you can think of leaving the tube inside, leaving it over there because these tubes are usually biocompatible. Now, we'll talk about what are the features of ventilation tube in our next class and what are certain features that you should be seeing in your ventilation tube. So because they are biocompatible, we can leave them behind and normally they'll not cause a foreign body reaction inside. So this is how displaced tube into the middle ear, the management of it will differ depending on the time at which it is presenting to you with. Lastly are our late postoperative complications. So if we look at the first image over here, we see our one of the complication is having a permanent perforation of the tympanic membrane. So here the tympanic membrane fails to heal after the tube has been extruded out. The risk in the of this complication is way higher, especially with usage of long-term tubes or repeated insertions of tube or even infections. These cases have to be treated with myringoplasty if the hearing loss is significant. Second complication here is tympanosclerosis. If you look at the second image over here, we can see this whitish chalky patches on the tympanic membrane, which occurs because of hyalinization and calcification of collagen around the site of tube insertion. Usually, this is a very common complication, and we do not need to worry as much about it because there's not much of functional hearing loss in tympanosclerosis here. Third complication, if you look at the image here, is an atrophic tympanic membrane. If you see the image here, you can see this part, how the tympanic membrane is looking very thinned out and atrophic. This can happen because of doing repeated procedures or chronic inflammation over there. And lastly, the last complication can be a retracted tympanic membrane. So these are all our complications that can happen because of Grommet tube insertion. And I have mentioned everything that I can about myringotomy over here and Grommet insertion. If you still have any further questions, please note them down in the comment section and I'll get back to you. Thank you.